Good evening. My name is Jennifer Bain. I'm a pediatric neurologist at Columbia University Medical Center at New York Presbyterian Morgan Stanley Children's Hospital. And this evening, I'll be speaking about seizure basics and epilepsy. As a disclosure, I am participating in some clinical research studies related to spinal muscular atrophy. However, I have no disclosures regarding the topics I'll be discussing this evening. This is going to be a two-part series, the first part of which I will be discussing Seizures 101 and Epilepsy ABCs. What is a seizure and what is epilepsy? What are different types of seizures? What's the difference between seizures and epilepsy? What are some risk factors for epilepsy? And some seizure first aid tips. In the second part, I'll talk more about seizure and epilepsy treatments, the diagnosis of seizures, treatments and side effects of treatments, as well as prognosis of seizures and epilepsy. For part one, again, I'll be discussing what is a seizure and what is epilepsy, different types of seizures, risk factors for epilepsy, and seizure first aid. To begin, the brain is made up of millions of different connections between individual brain cells called neurons. Each one of the small lights that you see here is representative of a constant electrical activity surging throughout the brain every second of your life to sense the environment around us, produce the movements that we have, make sounds, and communicate. There has to be a constant balance between all these different nerve cells in order to appropriately communicate. These signals that excite brain messages are often balanced by others that inhibit unnecessary brain messages. When there's an imbalance or an unbalance of these signals, that's when you have a seizure or an electrical surge of activity caused by these nerve cells. When a seizure occurs, there may be either too much or too little activity, causing this imbalance between exciting and stopping activity. The chemical changes that lead to surges of electrical activity are what causes seizures. Seizures itself are not the disease. They are a symptom of many different disorders that can affect the brain. A seizure merely means that there's something going wrong with the brain. Some seizures can hardly be noticed, while others are totally disabling. Where do seizures come from? Sometimes, if they come from one specific spot in the brain, we call it focal, because it comes from one spot in the brain. Other times, you might have multiple spots, such as here. We call this multifocal. Other times, when the entire brain seems to be firing off abnormally, we call this a generalized seizure. The brain is very smart and extremely organized. Different parts of the brain have very specific jobs. So, depending on where the seizure arises, this is what the manifestation or what the seizure will look like. For example, a seizure occurring in the olfactory cortex, which controls smell, may present with a person only sensing an odd smell. Rather, a person who has a seizure in the back of the brain or the occipital region, which controls our vision, may actually present with visual symptoms like visual hallucinations, since this is the part of the brain that controls our vision. Other times, seizures in the speech part of the brain will cause inability to speak or difficulty understanding speech. It's this complex organization of the brain which results in seizures looking very different from person to person. For example, a seizure may appear as convulsive, a sudden cry in a fall, followed by alteration of consciousness and unresponsiveness, followed by convulsive movements or shaking of all limbs. This might be accompanied by shallow or interrupted breathing, and sometimes the body will actually look white, bluish, or purplish, called cyanotic, and sometimes you'll lose bowel or bladder control. The individual will soon have a slow return to consciousness, after which they might be slightly confused or even tired. This will likely last a few minutes, but can even last up to a few hours. We sometimes call this a generalized because the entire brain has activity, tonic-clonic or shaking, or a grand mal seizure. Now I'm going to switch to a video, and I want everyone to note that I will be showing a graphic video of an individual with a seizure. I'll warn you prior to all the videos I show today. These videos are presented by the International League Against Epilepsy. Again, this is a generalized tonic-clonic seizure in which the person is completely unresponsive and shaking the entire body. This is in contrast to a different type of seizure that might be non-convulsive without any shaking. The person may actually look awake and may be somewhat responsive during that time. They might be able to respond to you, they might be able to talk to you, or just listen. They perhaps can have a blank stare and might make other funny movements with their mouth, such as chewing or other repetitive, purposeless movements with the hands or the body. They might walk around wandering, might be acting confused, and may even be making incoherent speech. On the other hand, a different part of the brain can sometimes present with crying, screaming, running, and flailing of the arms, while as others are a sudden loss of muscle tone and a fall, picking at the clothes, or disrobing. I'm going to show two more episodes. One is a partial seizure or a focal seizure because it comes from one spot in the brain. Staring episodes are called a very specific type of seizure, an absence or petit mal seizure. Notice that just one side of the body is stiffening and making a jerking movement, while the other side is not. He's actually awake during this episode. The second example is that absence epilepsy, or petit mal. Another type of seizure that I'd like to discuss with you today that may be important for some of you listening is called an epileptic spasm or an infantile spasm. A spasm is a sudden, abnormal, uncontrolled muscle movement. Typically, they emerge around 3 to 8 months of age, and they usually do go away after a few years of age. There's a very specific treatment for this type of seizure, and so early diagnosis and management is critical. In this video, notice again, it's a little baby. The baby has a sudden forced flexion of the neck and the arms. That itself is a spasm. Some children who have spasms will develop other kinds of epilepsy, and some will have developmental disabilities later in life. It is important to initiate steroid therapy and the anti-seizure medicine vigabatrin as primary treatment as soon as these are identified. The last seizure type that I'd like to discuss is called an atonic or a drop attack. This is when part of or all of the body may become limp. The eyelids might droop, the head may nod or drop forward, and the person may drop things. If standing, the person often falls to the ground. These seizures typically last less than 15 seconds. People may get injured when they fall, so it might be important to have a head protection such as a helmet or other protective gear if needed. They're called drop attacks or drop seizures. A seizure is a sign that there is something wrong or dysfunctional about the brain, causing this abnormal surge of electricity. Some of the more common causes of seizures are listed here, such as high fever, we often see in infants, drug use or alcohol withdrawal, near drowning or a lack of oxygen from some other cause. We refer to this as hypoxia or anoxia. Different metabolic disturbances, such as sugar too high or too low, or other electrolyte abnormalities, head trauma, both acutely as well as after the head trauma, a brain tumor, a brain infection, or a stroke, or a complication of diabetes or pregnancy. Another common cause of seizure is epilepsy. Epilepsy, also known as a seizure disorder, is a chronic neurological disorder characterized by recurring seizures that are not otherwise provoked by an acute injury or health emergency. The medical and scientific community has learned a lot about epilepsy syndromes, especially those who have no family history of seizures or other medical problems. In many cases, there are genetic causes identified that likely cause the epilepsy. Usually, these genetic changes are in the genes important in the brain function and brain development. It's important to realize that there should not be a stigma about epilepsy. There are many common figures that we see in social media that have epilepsy and have seizure disorder. There are many different types of epilepsy, each with their own very specific clinical picture. Very often, different epilepsy disorders present at different ages in the lifetime. For example, those spasms, called infantile or epileptic spasms, is a seizure type usually presenting in infancy under 1 year of age. Rather, absence epilepsy, when someone has those staring episodes or daydreaming, typically presents in school-age children, while juvenile myoclonic epilepsy, with brief jerks of the arms or legs, typically would present in adolescence. The age at which a seizure first emerges may provide clues to what type of epilepsy a person will have. It's really important to raise awareness that epilepsy is not contagious, it's not a mental illness, and it's not indicative of a cognitive disability. We do know that there are certain risk factors that puts a person at increased risk to have epilepsy. Some of them are listed below. Prenatal complications such as infection, fetal distress, exposure to maternal medication, drugs, or alcohol during pregnancy, complications during the birthing process itself, including maternal infection, prematurity, a lack of oxygen, small head size, or cerebral palsy. When an individual has developmental delays such as speech, motor, language, and social delays, this means that there is something inherently dysfunctional about their brain development, which manifests as developmental delays. This in turn will put them at an increased risk for epilepsy. Similarly, other neurodevelopmental disorders such as ADHD, autism, intellectual or cognitive impairment will also increase your risk of epilepsy. A family history of seizures, epilepsy, or other neurological disorders, including Alzheimer's disease, can increase your risk, as well as certain disorders of brain development itself. Central nervous system infections such as meningitis, encephalitis, or brain abscess, a brain injury or trauma, as well as brain tumors, will put a person at increased risk to develop epilepsy. And we're learning more and more about the role that genetics plays in epilepsy and brain development, which is how you came here today. Simon's VIP database has been a wealth of information. It has taught us a lot about individuals with certain genetic variants that may or may not be related to their developmental concerns. One of the common questions that patients are asked for in the Simon's VIP database is whether they have had seizures now or in the past. For this presentation, I asked Simons if they could provide information from their database about different genes and the risk of seizures. As you can see here, the column all the way on the right tells you how many patients out of the total number of genetic individuals in each group have been reported with seizures. This is all patient reported, please understand, but it can be very important. So an interesting trend that we see here is that the bolded genetic groups do seem to have an increased risk of seizures. For example, ADNP, PAX1, and then much more higher prevalences in disorders associated with SCN2A, STXBP1, as well as SYNGAP1, with nearly 100% of those individuals, although there are only 5 in the database right now, that have seizures. Remember earlier when I mentioned that nerve cells communicate throughout the brain? And when the balance of this communication goes into disarray, this is what causes a seizure. This figure shows 2 nerve cells, one purple on the top, one blue on the bottom, sending each other chemical signals that are important for these messages. On the right, notice different names representing each of these different molecules involved in this translation between the 2 nerve cells. Notice that some of them, SYNGAP1, STX1B, STXBP1, are actually the genes that we know in our Simon's VIP database that are shown to have high prevalence of epilepsy. It makes sense. If these molecules are critical for nerve cell communication, when there's something wrong with them, for example, when our genetic code is incorrect, their absence can lead to an increased risk in seizures. Many of the other genes we know from the Simon database are also very important for this brain messaging system. And if there's any problems in these cells with genetic codes, you're at an increased risk of epilepsy and seizures. Based on the data that I showed before, we wanted to ask a little bit more about the types of seizures. So we'll use, for example, on the bottom, SYNGAP1. There's only 5 individuals in this group. However, 100% of them do have seizures. And what types of seizures are they reporting? Grand mal, or those generalized tonic-clonic seizures, petit mal seizures, which are the absence or staring episodes, spasms, which are those brief little jerky movements in little babies, drop attacks, which are often the loss of tone. It's important to recognize that different seizures can present in different genetic groups. You might be on the lookout a little bit more if you realize that you are at an increased risk of seizures based on your genetic variant. This is the power of precision medicine and recognizing what your genetic variant is and whether it's related to your developmental problems, such as epilepsy or other developmental delays. One of the other powerful things is that we can share when these seizures actually started. So we can learn whether or not these are seizures that present early in life, for example, at 3 months in the PAX1 group, or later in life, such as SYNGAP1, when they present at 42 months of age. We can also look at how frequent these seizures actually happen. Are they occurring once a year, or do they happen perhaps multiple times a day? The Anita Kaufman Foundation is a wonderful nonprofit organization. They aim to educate the public not to fear about epilepsy and seizures. We need to understand and appreciate that 1 in 10 people will have a seizure in their lifetime. And do you know how to respond? Theoretically, anyone with a brain can have a seizure. The first line of response when a person has a seizure is to provide general care and comfort and keep the person safe. The information here relates to all types of seizures. First and foremost, try to stay calm. I know this is easier said than done, but most seizures only last a few minutes. It will likely seem like forever when the seizure is actually occurring. Here are some tips to consider if you witness a seizure. Always stay with the person until the seizure is over. Seizures can be unpredictable, and it's hard to tell how long they may last or what will occur during them. They might start with very slight symptoms, but this might lead to a loss of consciousness or even a fall. Other seizures can be very brief and end in seconds. If you're able to, you should really encourage yourself or somebody around you to look at their watch and to time the seizure from the beginning to the end of the active seizure. If this is a first-time seizure, you do not know the person, or the seizure lasts longer than their typical events, you should call 911 for help. Injury can occur during or after a seizure, requiring help from other people. In some cases, you might know that the person has an emergency treatment or a rescue medication prescribed. Know when these medications should be administered and how they should be administered. Remember, if the first person there remains calm, it will help the others stay calm too. Talk calmly and reassuringly to the person during and after the seizure. It will help as they recover. Try to prevent injury by moving them to a safe place. For example, if they're located on an unsteady or elevated surface and at risk for falling, move them to the ground if you're able. It may be easier to move nearby objects out of the way. Remove sharp, dangerous objects from the area. If you can't move things around them, or if the person is wandering and confused, just try to help them steer clear of dangerous situations. For example, try to keep them away from traffic, a nearby train or subway platform, heights, or sharp objects. If they try to walk around, let them walk around in a safe enclosed place. Do not try to hold them down or stop the movements during the seizure. Restraining them may actually cause injury and make them more confused, more agitated, and even aggressive. You can try to support the person's head to prevent it from hitting the floor. And once the situation's under control, encourage people around to just step back, give the person some room. Waking up to a crowd can be embarrassing and confusing for a person after a seizure. Do not put anything in their mouth. The jaw and the face muscles may tighten during a seizure, causing the person to bite down. If this happens when something is in the mouth, the person may break and swallow the object or break their teeth. Don't worry, a person will not swallow their tongue during a seizure. Try to check their breathing. You can turn them to the side if they're laying down. You can point their mouth actually down to the ground. It sounds silly, but this actually prevents saliva from blocking their airway and helps them breathe more easily. During a convulsive or a tonic-clonic seizure, it may look like they stop breathing. This happens because the chest muscles tighten during the tonic phase of the seizure. As this part of the seizure ends, the muscles relax and the breathing will resume normally. Generally, you do not need to do rescue breathing or start CPR. If a person is not fully awake or aware of what's going on, they may not swallow correctly. Please do not give them any food, any medicine, any liquid. It could go into their lungs instead of their stomach if they try to drink at this time. And if a person appears to be choking, turn them on their side and call for help. If they're not able to cough and clear their air passages on their own, or they're having breathing difficulties, again, call 911. After the seizure, remember, seizures are frightening for that person, as well as for those around them. They might be embarrassed or confused about what happened. Keep this in mind as they wake up. Reassure them that they are safe. Once they are alert and able to communicate, tell them what happened in very simple terms. Offer to stay with them until they are ready to go back to normal activity, or call someone to stay with them. I mentioned a lot in the last slide, so let's just summarize and say what not to do. It sounds like a lot. Just try to remember what not to do. Don't hold them down. Don't try to stop their movements. Don't put anything in their mouth. Don't try to give mouth-to-mouth like CPR. And don't offer them any food or water until they are fully alert. When to call 911? If you're really worried, call 911 right away. There's not ever going to be a problem if you do call. But if you are asking yourself, should I call 911? Ask, has this person ever had a seizure before? If it is their first time seizure, they likely should go to the hospital. If a seizure lasts more than 5 minutes, if one seizure occurs right after the other and they're not returning to themselves or regaining consciousness between the seizures, if they have difficulty breathing or appear to be choking, if the seizure occurs when they're in water, if an injury might have occurred, if they ask for medical help, or if they have other medical conditions like diabetes, heart disease, or are pregnant, they should probably have 911 come to evaluate the situation. The American Red Cross and the Epilepsy Foundation have each developed first aid applications that are free to download with instant access to step-by-step first aid advice, including advice about seizures and epilepsy. One tip that I always provide to parents is use your phone to record any episode you're not sure whether it is a seizure or not a seizure. The use of technology is gold for a clinician such as a pediatrician or a neurologist to determine whether an episode is concerning for a seizure. Stay tuned for the next segment regarding workup of seizures and epilepsy treatment, along with basic prognostic information for epilepsy. Thank you. Have a good night.